I've been making this series of videos on people who've been very controversial, who've had a lot of false allegations made against them, people who've done the kind of work that nobody else seems to want to do, and they're trying to answer some very difficult questions. And one of those people I wanted to have on many months ago when it comes to trans issues and other issues as well, Dr. Ray Blanchard. And I am very happy and honored to have him here. And I'd like Dr. Blanchard, please, to introduce yourself and let us know how you came to be in this field.
My name is Ray Blanchard. I'm now retired, but I worked for 30 years at the Clark Institute and the Center for Addiction and Mental Health doing research on human sexuality. My interest in this field really began when I was already 33 or 34 years old. I was working at my first permanent full-time job after I had finished my postdoctoral work, and I worked in a place where there were a lot of sex offenders. There was a man there named Kurt Freund who invented Phallometric testing, which is a way of determining someone's sexual interest, possibly against their will, by measuring penile blood volume while you show them a series of stimuli depicting males and females, adults and children, and so on. I was very intrigued by the idea of a laboratory test for a psychiatric condition. And so what really got me into sex research was not interest in studying human sexuality at that point, but rather this idea of a lab test as opposed to MMPIs or whatever else my job required me to do at that time.
Right, and just for those who don't know, MMPIs are pen and paper tests that people do, basically to personality questions or things like that. You wanted real-life physiological measurements, right?
Yes, I wasn't comfortable with interpreting personality tests and whatnot and making diagnostic statements, especially when there's as much at stake as there is for men who are in prison. So I thought that the phallometric test was really cool. This attracted me. Then secondarily, I started getting interest in human sexuality per se and didn't know whether I would ever have that as a career. But then a job came open at the Clark Institute in the Gender Identity Clinic, and I applied for it. Although I wasn't specifically interested in transsexualism at that time, I was really more interested in sex offenders. But I knew that jobs in clinical sexology with a research component didn't grow on trees, so I applied for the job at the Gender Identity Clinic, and that was how I started as a career professional working in that area.
Now, you mentioned the phallometric testing. So for those who don't know, I mean, we hear about it in the movies and so on. Can you describe, for both for men and for women, and were you ever working with women, or was it always men in your case?
Always men.
Okay, but maybe you can also describe for women. Can you describe what exactly the process is, not just the mechanics of it, but also the stimuli that you'd mentioned?
The phallometric testing is a way of assessing somebody's erotic preferences by measuring penile blood volume while they're shown a series of stimuli that would depict, let's say, little boys, teenage boys, adult men, the same thing, little girls, pubescent girls, adult women, or there could be other stimuli depending on what you want to test for. But as I said, you're showing these stimuli one after another to a person while you're monitoring penile blood volume. Typically, you're looking at small changes in blood volume, not full erections, because the stimuli aren't usually that strong. The reason for this is that really a small percentage of people, let's say who've molested a child, will come in clinical interview and say, "Yup, I did it because I wanted to do it, and I'm really sexually attracted to children." So self-report is very problematic, very unreliable when you're interviewing sex offenders. If a sex offender continues denying erotic attraction to children but has offended against, let's say, 6 or 8 or 10 prepubescent children, you can just make your diagnosis and say, I don't care what the patient says, the patient's actions speak louder than words, and this man has an erotic preference for children. But in many, many cases, maybe your modal case, you've got a guy who comes in with one offense that you know of against a prepubertal child, and the odds are like 50-50 that he is or is not really pedophilic in the sense of preferring the immature physique over the mature physique. And in those cases, your only clinical approach is with phallometric testing to measure penile response while the guy views these stimuli. It's not perfect by any means, but it's better than any other option at that point.
Now, we do know, sadly, that child pornography exists. It's reprehensible. Is it a legal, is it a moral, is it an ethical decision, for example, not to use that harder core types of material in order to try to elicit responses from suspected child sex offenders?
Well, the labs that do this diagnosis don't use child pornography. I don't know whether we did it for moral reasons or, I mean, these decisions were made like 40 years ago before my time because I continued using the stimuli that had been assembled by my predecessor.
Okay.
But the stimuli we actually use basically look like illustrations in a medical textbook. You just have people of different ages and the two different sexes standing naked against the wall, pretty much, like I said, looking like an illustration in a medical textbook of pediatric endocrinology or something like that. And they're not what most people would think are sexy. They're pretty weak. And that was considered by my predecessor as a feature and not a bug. And that was the stimuli that I continued using. Whether, frankly, pornographic, pedophilic stimuli would do the job where weaker stimuli don't, I don't know. It might increase your sensitivity, but also increase your false positives, because maybe if you have an 8-year-old girl interacting with an adult man, it might start to squeeze a reaction out of a guy who doesn't actually prefer the immature physique. So it's probably best to stay with the weaker stimuli because you don't want to make false positive diagnoses. It's better to make false negative diagnoses.
Okay. Now, that's a hard sell for some people because they would say false negative, you're letting pedophiles go, basically. You're letting monsters return to society. But do we want to have people being falsely accused of being child sex offenders or pedophiles, which are two different things, which I talk about with Dr. Cantor, of course.
Yeah, I mean, in the context in which patients get assessed, most of them have already been convicted. So they're being sent for testing, say, by their parole and probation officer who wants to determine what's the best kind of treatment for them. If like you have one of these one-case offenders, maybe a guy offended against a 13-year-old stepdaughter, okay, is he more appropriate for treatment for a pedophile, or is he more appropriate for treatment for alcoholism or impulse control or something else? So it speaks to what treatment you want to give, whether you're treating an anomalous erotic preference or some other kind of behavioral problem that led to a one-shot offense against a girl of maybe borderline age.
There's a famous study, at least in our area, and I thought it was more than one. I know there's one that's always cited, where they said that non-pedophilic men who were shown these stimuli, 25% of them showed some arousal to that.
I've done a couple of them.
Okay. Was that the same, you were using the same methodology and everything? Or?
In one study I was involved in, we just took like the most gold standard normal guys you could possibly assemble. They had no history of offenses against children. They didn't report any sexual interest in children. And their phallometric testing showed that their strongest response was to adult females. So if you then examine, well, how much did they respond to little girls? Yeah, there is some minute, tiny trace of a response. Maybe it's just the sight of a vulva. But the point is, when you do phallometric testing, you don't just give the guy stimuli depicting children. You give him stimuli depicting children and adults, and you make your diagnosis from where is the strongest response. So the fact that there might be some tiny vestigial response to prepubertal children, that doesn't affect their diagnosis. We know that happens. We know a guy's going to respond more to an 8-year-old girl than to a photograph of a tree or a landscape. But that's not how the diagnosis is made. It's compared to how much does he respond to a good-looking 20-year-old.
And that's why I'm asking about this, because if some layperson reads about this and they hear, 25% of men got aroused, this will feed into this whole, there are child sex offenders everywhere, or the pedophile rings that are running the country or the world. And so they want to take this information and use it to further any type of agenda they have. So I wanted to get the expert to clarify that. So that was the first question. The next one is, I know that, I think at CAMH as well, in their center that they used to have when they did the phallometric testing, they also sometimes use, I think, audio stimuli, like they portray an event. Can you describe that a little bit?
When I took over the lab in 96, Kurt Freund had run the lab until 96. He stepped down in 96, and then I succeeded him as running that lab, at least at a research end, and also took care of the equipment. And I realized that we used to use these brief movie clips. They were basically deteriorating too much. I just couldn't see continuing with them. So I wanted to go with photographs instead, but the still photographs, as I described to you, looking like medical textbook illustrations, they just weren't quite strong enough. So what I did was I wrote a series of stories. Each is about 54 seconds long. So if I'm showing you a photograph of an 8-year-old girl, you're hearing about a minute-long story about how you're interacting sexually with this 8-year-old girl. Okay. If I show you a photograph of a 25-year-old man, along with that, you're hearing a story about sexual interaction with a 25-year-old man. So the two things together kind of beefed up response, and we were getting better results than we got with slide stimuli alone.
And to change gears a little bit, because I said earlier about this, I don't want people to think I'm using pedophilia and child sex offense or offenders interchangeably, because we know there's overlap, but they're two different phenomena. Every time I say that on Twitter, I'm opening the gates of hell here, okay? And Dr. Cantor and I talked about this a lot, but I'm curious, from your perspective, are you on board with the work that Dr. Cantor and Dr. Michael Cito are doing, indicating that pedophilia may be like an orientation or something that they're born with, rather than saying that they're all just these perverted monsters?
Well, yeah, I think that quite possibly pedophilia has prenatal origins. James Cantor and I together, he was my postdoctoral student at that time, I think, did the first MRI study of pedophilia. And I had previously been doing research even before he came along, suggesting that pedophilia might result from some perturbation of neurodevelopment in utero. And so, yeah, I think that probably it will turn out that pedophilia has some, maybe not always prenatal, maybe it can result from an early head injury or something like that, but I think it has a biological basis.
And when you were doing,
I don't think it results from moral turpitude, no.
Okay. And again, that's still a hard sell, no matter how much data you show. It's for so many people, rightfully so. I mean, it evokes such a strong reaction that people don't want to even hear it. They just want to say they're all monsters, lock them up, even if they've never offended, right? It's a tough call. And so I say to them, we need to understand this better. And you were saying that in many cases, it's a one-off where they've offended against a child, but it's not about pedophilia. Maybe it is the alcoholism or control or whatever else it is. So why would we treat them the same? Well, of course, for them, they think treat them all the same, just execute them all, problem solved. But I try to tell people this is a real-life condition. It affects, we don't know what percentage, maybe 1%. I asked Dr. Cantor, I mean, it's impossible to estimate. He says anywhere between 0.25%, I think, and 1% maybe might be the target range he feels comfortable with. But, and then other people say, no, it's much higher. Again, like you, I get attacked by both sides. I get attacked by people thinking I'm pro-pedophilic. Then I get the pedophiles themselves coming on and saying I'm horrible for even suggesting there's anything wrong with it, and I should recognize that the rates are much higher. How do we know how high it is? And that no, the chances of being a child sex offender are not greater if you're a pedophile.
Given that you have X offenses against children, what's the probability that you're really a pedophile as opposed to one of these other guys who did it for whatever reason? And so that varies by how many offenses. I would say, I think most people roughly agree, a guy who has one offense against a prepubertal child, it's roughly 50-50 that he actually prefers the immature physique versus, one of those stuff happens situations. And then the more offenses against a child you get, the higher the likelihood that the guy has a preference for the physique of the age he's offending against. Okay. But I can't go the opposite way and say, given that you have an erotic preference for children, what's the likelihood that you're going to commit an offense? And I don't know if anybody has those kind of numbers.
Right. Yeah, no, I was actually meaning that if we found child sex offenders, you just described, you said it's 50-50 if it's one child. The more children that there are, the higher the probability that they're an actual pedophile versus, again, as I said, something happens. And when people hear this, again, because you're so immersed in the field, you've done so much work on this, people would misconstrue that as saying, oh, is he just dismissing child sex offenders as something happens? No. But people are looking for anything, any reason to pillory you so that they can negate everything else about you. That's where we are today.
Well, the punishment angle gets taken care of by the criminal justice system. That's not the job of the clinician. The job of the clinician is to say, what kind of treatment for this particular person is the most likely to see that this kind of offense doesn't happen again? And it does matter for that kind of clinical decision why it happened in the first place.
Right. And I saw a documentary. I don't know when it came up. I saw it this year. It was very brief. It was like 7 or 9 minutes, where they were saying that there was only one report that came out years ago, and it wasn't based on anything, no legitimate science, that said that child sex offenders have these huge recidivism rates. This is in the States. And they say that's guided all policies. And then they said, however, if you look at it, the rates of recidivism among child sex offenders is actually quite low compared to other offenses. Have you seen this documentary?
Well, I didn't see the documentary, but I knew that recidivism rates are relatively low in sex offenders. I knew this already.
The whole point about this documentary was that no one talks about this, that it seems, we're talking the States here, and I'm not familiar enough in Toronto with what the narrative is, but they were saying that so many men have had their lives ruined, they can't get a job for the rest of their lives, they have to register as sex offenders forever because of this narrative. What is it like up in Canada then? I mean, is there more education around the real rates?
No, it's the same situation, that people who actually work in the field take for granted that the recidivism rates are pretty low, and people who don't work in the field have this notion that recidivism rates are very high. And it's just a disconnect between what's known by the experts and what somehow makes it out into the popular culture. I don't think you can even hold the media at fault here, because in this particular race, I don't know that the media has an agenda here. Right. I just don't know why there's this disconnect, but there is.
Okay, well, to me, the greater disconnect would be then the experts as far as the clinicians and the justice system. Is there the disconnect, or does the justice system take into account what the experts say?
I would say the justice system takes into account what experts say. Psychiatrists testify, or forensic psychologists, they testify, especially at sentencing hearings when it's going to be decisions made, or whether, where the judge is going to send the guy, whether it's some place that specializes in treatment or whatever. The justice system, they probably mostly have some idea what recidivism rates are.
Okay, because in this documentary, that was a big part of it. They were saying that the justice system does not, in the States, does not reflect the reality. So that's why I wasn't certain of how it was here.
Well, their practices might not reflect the reality, but certainly the data are available to them.
Yeah, but that's what they're saying.
Recidivism come from the justice system. Individual clinicians are not in a position to collect those data. The data come from jurisdictions that track reconvictions. It's harder to do in the U.S. than Canada, because in the U.S., reconvictions and whatnot are in state databases, which are not necessarily coordinated in any kind of way. In Canada, it's a federal database, so you can get better data in Canada.
Okay. Yeah, well, that was the whole point of this documentary, that they're saying that the way the justice system treats child sex offenders is not reflective of the actual data. And then by me saying this, again, no skin in the game. It's terrible, obviously, to offend against children. I've worked with the many people who've had the trauma of this experience, but I'm just trying to be practical, because if a person, if they've had one offense, they're not a pedophile, they're not going to reoffend, but we basically make it so that they can't live their life in any normal way, then I think we're increasing the odds of them lashing out or doing something very destructive once again, versus having a system that reflects the reality and that maybe we can reintegrate them into society and make them productive members, rather than hiding out under bridges or being on the the welfare system or something like that because they can't get a job. I'm just being pragmatic about it.
Yeah, I think a lot of people recognize that the current ways of dealing with sex offenders in the criminal justice system is not necessarily in anybody's interest, including that of society. But the desire for vengeance and the need for virtue signaling is just so powerful that it swamps practical considerations.
This is the next question again. I'm trying to set the premise being that child sex offenders and pedophiles are two separate phenomena, even though they do overlap. When it comes to actual pedophilia, and I know it's impossible to know, but I'm just trying to get with all of your experience, how optimistic are you that with the proper treatment and so on, that a pedophile can refrain from acting on their impulses?
I think that's a realistic treatment goal because a lot of people refrain from further sexual offending just from the trauma of being arrested and convicted and doing a little time. So yeah, I think it's realistic that many cases can be helped by therapy to refrain from offending again. I see that as a realistic goal. I don't think it's realistic to say we're going to extirpate your feelings for children and replace them with lust for nothing but adults of your preferred gender. That I would say is an unrealistic treatment goal. But controlling yourself, yeah, why not? Most of us control ourselves most of the time.
And are you aware, again, I don't know if you can estimate these things, on record, what percentage of pedophiles are exclusively pedophilic and what percentage have both adult and child preferences?
I kind of don't like that. I think that this distinction between exclusive pedophiles and non-exclusive pedophiles is somewhat artificial. If you think of a diagram of a mean and a standard deviation, all of us have our thing that we like the best, and they can differ. But all of us also have a spread of what we'll take that's outside of our favorite. And I think just as people differ in what age is hottest for them, people also differ in how wide a net will they cast. So to me, exclusive pedophile, non-exclusive pedophile is not two different species. It's a matter of degree. You could say the same thing about I use the word teleophile for men attracted to adults. You have your exclusive teleophiles who have absolutely no interest in anything under 14, and then you have those who, 45 doesn't look that bad, and 14 could be acceptable, maybe.
Right. The reason I asked was, I was thinking practically speaking, if there's a pedophile, if they have a wider interest, it might be easier for them then to divert that energy and say, focus on these people you're already interested in versus someone who's exclusively attracted. Do they stay then celibate for the rest of their life? Is it possible to make them more interested in adults? I don't know enough whether that's even possible. If someone's exclusive, could they ever be interested in adults?
For the heterosexual pedophiles, I think they start out by having more interest in adult women than the homosexual pedophiles have in adult men. So I would say probably for the heterosexual pedophiles, it's easier to say, this might not be your number one choice, but stick to the older females. I think for the homosexual pedophiles, the difference in physical appearance between a prepubertal boy and an adult male is just too much of a stretch.
A lot of people don't know this, and I know that I shocked a lot of my friends when I was teaching human sexuality, and so they had younger girlfriends. They might be in their 20s, late 20s, maybe their 30s, and they were terrified that maybe they had broken some law. And at the time that they were asking me this, I think it was pre-2000. I want to say it was 8 that the law changed. But a lot of people didn't realize that in Canada, right, the age of consent where somebody could have sex with anybody they want as long as they're not in a position of authority was 14. A lot of people didn't realize that. Everybody assumes it was at least 16. And I know a lot of people in the States thought we were a country of pedophiles because, 14 was that law. I think it was, again, I'm pretty sure it was 2008. Where it changed to 16. And then there's all these variations that if you're, if you're 14 or 15 now, as long as the person is no more than 4 years older than you, people need to realize that for many years, 12 years old children can give consent as long as the other person is 1 or 2 years older than them. I'm just saying this to say that the laws reflect certain realities of sexuality, that kids are having sex at certain ages. So I'm curious with you, I don't know if you were involved in any policy making or if they came to you when they raised the age from 14 to 16. Did you have any say in that or did you have any thoughts about that?
I had no part of it. I certainly wasn't consulted. That was some legal decision made. I didn't have any particular thoughts about it. Wherever you set a cutoff of any sort, there's always a trade-off between how many wrong decisions are you making in one way and how many wrong decisions are you making in another way. I guess I'm just accustomed to thinking of, well, you move your line, you're going to get more false positives and less false negatives or whatever. So, to me, 14, 16, it wasn't something I had strong feelings about.
Okay. And again, you answer these questions with such a rational almost statistical based perspective. For other people, just mentioning that question, trigger, they have a hard time wrapping their heads around it. So I appreciate being able to have this discussion. I want to be sensitive to it as well, of course, because many people have been taken advantage, abused, had horrific things done to them, and none of this is to minimize that. It's just that we're having a rational discussion about these realities. I mean, the laws have to be made. We have to have cutoffs. So I always have to say these caveats so that people don't, they're still going to misconstrue what we're saying, but I'm trying to minimize that.